All right, so we're going to talk about peripheral arterial disease. Peripheral arterial disease and peripheral vascular disease are the same thing, so don't confuse them and think that they're two different things. They're the same thing. PAD refers to any disease process which affects the arteries. So it's basically arthrosclerosis in the arteries. So you have like a hardening of the arteries, plaque buildup of the arteries, and this causes you to, or the patient, to not have a good circulatory, a good peripheral system with a good circulation. The severity depends on the type, the extent, what stage they're in, as well as how quickly things develop. I know you guys love that. Those that have peripheral arterial disease are not receiving treatment, and the reason they're not receiving treatment is because they don't realize that they have the disease. Peripheral arterial disease risk factors, the biggest modifiable risk factor is smoking. I cannot scream it loud enough. Nicotine, it decreases our blood flow, it increases the heart rate, increases the blood pressure, albeit temporarily, and increases our risk of clot formation by increasing the aggregation of platelets, makes our blood more viscous. Smokers have a 4-fold higher risk of developing pain from arterial disease than non-smokers. So your people that have intermittent claudication, they're 4 times more likely to have intermittent claudication if they smoke, or rest pain if they smoke, versus those who do not smoke. So modifiable risk factors, other modifiable risk factors: diet, exercise, obesity, stress, diabetes, and high blood pressure. Our non-modifiable ones are genetics, ethnicity, the female gender, and age. So some signs and symptoms of peripheral arterial disease. We have coolness in our extremities, a weak pulse, color change, numbness, weakness, delayed sore wound healing, just like with diabetes, hair loss or slower hair growth because you need good circulation for hair to grow, nails that grow slowly and are thicker, erectile dysfunction, and painful muscle cramping with activity. Also, we have the person with peripheral arterial disease will have thin skin and shiny skin because they don't have good circulation. So up to 5% of the population with peripheral arterial disease are going to have what's called critical limb ischemia. Critical limb ischemia is chronic ischemic pain at rest pain. Please do not confuse rest pain and intermittent claudication. Rest pain is something that needs to be dealt with immediately, almost. It's a sign that there's some sort of significant arterial insufficiency going on. Those with chronic limb ischemia also are going to have non-healing ulcers and gangrene. Why? Because they are not getting the circulation that they should be. And it's drastic. Acute limb ischemia, which is even more of a medical emergency, is having a sudden decrease in perfusion to extremities, mostly caused by clots, but it can be caused by other things, anything that would cause a decrease in circulation. So, the 6 P's of ALI, we have polar, which means coolness, paralysis, paresthesia, which is like tingling, numbness, pallor, which means paler than like the rest of the body, pain, and pulselessness. Again, hallmark symptom of peripheral arterial disease is intermittent claudication. Intermittent claudication is not rest pain. If a patient has rest pain, there is a sign that something significant with arterial insufficiency is occurring. Intermittent claudication is going to occur in the legs. Rest pain is going to occur in the feet. There's the diagnostic tests, which I talked about pretty well, I think, in class today. So patient-centered care of the person that has peripheral arterial disease. You're going to want to encourage exercise to help build collateral circulation. The way that you're going to do this is to tell the patient that they should initiate an exercise program gradually and then increase slowly. You want them to walk into the pain and then rest. Why do you have them do this? Because when you're walking into the pain, when pain starts, that means the tissues in the muscle are not getting the oxygen, and they're not getting the oxygen from the arteries. So if you need to rest the muscle so that it can get the oxygen it needs, the pain can go away, and then the patient can start all over again. You want to help promote vasodilation and avoid vasoconstriction. So you want to educate the patient on things that can cause vasoconstriction, things like nicotine, caffeine, stress. Promote vasodilation. So you want to explain that they should be in a warm environment, insulated socks, not to apply direct heat to their extremities because they could have a risk of burning themselves, just like with diabetic neuropathy. And then positioning, you want to have them not cross their legs because that can cut their circulation off, not to have constrictive clothing, and to elevate their legs, but not to elevate above the level of the heart, because our problem is getting our blood supply down our extremities. So if they're elevated above the heart, then you're increasing the gravity that their blood flow has to overcome. Also, please do not confuse sequential compression devices with PAD. You do not use SCDs for PAD. You use them for venous. You also do not use compression stockings for PAD. You use compression stockings for venous. So the patient will be on some kind of antiplatelet medicine. If a stent is placed, that's going to be clopidogrel or Plavix. If there is no stent, it will be most likely aspirin. So what happens with this antiplatelet? So antiplatelet medicines help to keep our platelets from aggregating. So it makes our blood less sticky, less viscous, which helps the blood flow. You want to inform the client that the medication's effect might not be apparent for several weeks and advise the client for evidence of bleeding. They need to monitor for evidence of bleeding, such as abdominal pain, like significant abdominal pain, any type of black or bloody stool, coffee ground emesis, tarry looking stools. Now, people with hemorrhoids, they might have some rectal bleeding, but this is generally bright red. So when the stool is tarry in appearance, black in appearance, it's coming from a higher source. Also, if they're on an antiplatelet, you want to advise them to not take any other medicine that might promote bleeding, such as like an NSAID. So if they're having pain and they're on something that already it promotes bleeding, they might need to just take an acetaminophen instead of a Motrin. So another medicine is phosphodiesterase 3 inhibitor. The brand name, or not the brand name is Pladol, but the name is Solostazole. And this is your first-line pharmacy for claudication treatment. And when you combine that with an exercise program, it's going to help improve the walking distance of the patient. But there is a black box warning on this medicine, and it's contraindicated in heart failure. And statins, which I'll talk about more next week, can relieve manifestations associated with peripheral arterial disease. Some significant things with statins is your big side effect is rhabdomyolysis, which is basically the body eating itself. It can affect the liver, and you shouldn't drink grapefruit juice with them. When we have ALI, we need to revascularize. So surgical management is arterial revascularization is our first line with severe claudication and or loss of limb. Now, if there's a life-threatening emergency, they might go with amputation. But if it's not a life-threatening emergency, they're going to go with revascularization. So the actions for this revascularization is to maintain adequate circulation. That's our priority. We're also going to look at the color, if this is when they come back from surgery. We're going to check the color of our foot, look at the temperature of it, check for redness, edema, and increased sensation. So check pedal pulses. We're going to check our incision site because we want to check our incision site for any type of bleeding. Want to check our incision site for hematoma. We are going to tell the patient that they need to limit their bending. So depending on what kind of procedure they had will determine how long their bending is going to be limited. So their bending can be anywhere from 2 to 6 hours. It just depends. I know you guys love that answer. And then we need to assess their urine output, assess vital signs, and assess for pain. So this is just a picture of a FemPop. And Ms. Poindexter talked a little bit about what it looks like in the OR, since I have not seen that in the OR. Complications from those things. You could have an occluded graft. An occluded graft, you might have signs and symptoms of a cool foot, no pulses. It's a serious complication of arterial revascularization. If it's going to occur, it usually is in the first 24 hours. The surgeon needs to be notified immediately if anything happens, anything like this happens. So they have an absent or reduced pedal pulse. They have increased pain. Their extremity color has changed. It's cooler than what it was. These are all symptoms of graft occlusion. And they might need a thrombectomy for this to take out a clot. Maybe a clot's causing the graft to be occluded. Then you have graft infection, wound or graft infection, and that's pretty self-explanatory. You want to use sterile technique whenever you're changing a surgical dressing or providing wound care. So, always be sterile when you're changing a surgical dressing. And then compartment syndrome. So that is also a medical emergency. And it's basically the tissue pressure has built up. It's been confined. The dressing is restricting blood flow. And so ischemia results, and that leads to irreversible tissue damage. So what you need to do as a nurse, you need to loosen the dressings, and you need to let the provider know. So some symptoms that you would see in the patient, tingling, numbness, worsening pain, edema, passive movement pain, unequal pulses. These are all things that should be immediately reported to the provider. And then you want to prepare for a fasciotomy, which is opening of the skin to help relieve the pressure. So, like I said, you should really watch this video. They explain wounds very neat. The two Northerners that are in the video are wound care nurses, and they can get the they talk about wounds pretty relevant, I think. Matter in this. So there's a big X on the neuropathic. So you have an arterial wound and a venous wound. So arterial wounds need to be kept dry, and debridement cannot occur until they have been revascularized, because that means if they have an arterial wound, they do not have good circulation to the wound, therefore they cannot heal. So if you try to debride it, you're going to cause issues. Arterial wounds are going to be shiny looking, they're going to be pale, they're going to be like a desert, dry and arid. Then you have venous wounds, and venous wounds are, the problem is they can't get the blood flow back up to the heart. So those types of wounds are going to be, so the venous wounds are going to need to be debrided. They're going to be like, there's going to be a lot of drainage. They're going to be reddish because the blood is pulling. They're going to be edematous. So you're going to need to debride them. You're going to clean the area with saline or whatever the doctor has ordered, and if they haven't ordered something, clean it with saline. Or a non-cytotoxic substance, which at ANMED it's called Dakins. So whatever facility you're in is what you'll be using. And then you're going to have different types of debridement based on what the doctor orders. There's the wet to dry debridement, which occurs more on a surgical floor, I believe. And it's a not really sterile, even though they taught me sterile, but it's more of a clean technique from what I've seen. And it's wet to dry, so you kind of make the dressing wet and you stuff it in the wound, and then when you take it out, it's dry and it takes stuff with you. It is non-selective, so it'll take out good and bad, and there's much better options these days, so I don't know why the surgeon doesn't order better options. There is another option, is the enzymatic debridement, which is a little bit more expensive. Well, it's actually much more expensive. And it's just special ointments, and the enzymes of the ointments help to eat away the bad stuff, basically. And then you have the autolytic, which is they put a dressing on top of it, and that dressing helps to get your own juices into it and helps to destroy like the bad material. Please do not debride a venous or an arterial wound until the circulatory status has been deemed adequate for wound healing. So with a arterial wound, that's not going to be until after you have had a revascularization occurring. When the ulcers are infected, you are going to give antibiotics. I'm not going to discuss the types of antibiotics. So that is peripheral arterial disease, and then I'm going to talk about some venous disorders in the next episode.